Today we will do the shoulder joint. The shoulder joint of the upper limb is the ball and socket joint, and it is the synovial variety of the joint, and it is a multi-axial joint, so we can rotate the arm in any direction. So that is the specialty of this joint, that the movements, they are very wide range as compared to the hip joint. Now we will discuss the shoulder joint under the headings of: number one is the bones taking part, then the ligaments and the fibrous capsule, then the movements, and then the applied of the, and then the blood supply and the nerve supply and relations of the joint. So we'll take one by one. Now the bones which are taking part in the joint formation, on one side there is a humerus bone and another side is a scapula. But which part of the humerus bone and which part of the scapula, that we have to discuss under the bones taking part. As we know, is the joint formed within the spherical head of the humerus, and it is smooth. So we have to make the diagram of the head of the humerus, and this line shows the anatomical neck of the humerus, and this is the greater tubercle and this is the lesser tubercle, and this is the intertubercular groove, or what is called the bicipital groove. And this surface of the spherical head of the humerus is smooth. It is smooth because it is covered by the hyaline cartilage, which makes the joint frictionless and stable, and is long-lived joint. So this is the anatomical neck around it, the head of the humerus. And on the other side, the joint is completed by the scapula. And which part of the scapula? The lateral angle of the scapula, or lateral angle is also called glenoid cavity. So glenoid cavity is on the other side. It is triangular in shape, broad below and it is narrow above, but it is a shallow cavity as compared to the acetabulum. And above here there lies the supraglenoid tubercle, and below here also lies the infraglenoid tubercle. So this is the bony rim of the glenoid cavity. So this is how the joint is formed between the shallow glenoid cavity and the head of the humerus. So that is the movable joint, that is the variety of the synovial variety of the joint. And glenoid cavity is also very smooth. Again, it is covered by the hyaline cartilage, which is also called the articular cartilage. So articular cartilage of the head moves on the articular cartilage of the glenoid cavity, and this joint is smooth and frictionless. So after discussing the bones taking part and their shape and size and everything, now comes the next part, is the fibrous capsule and the ligaments of the joint. The fibrous capsule keeps the two bones together in all movements of the joint, and the attachment of the fibrous capsule is very, very important. So the fibrous capsule which is attached first to the humerus, so it is attached circumferentially over the anatomical neck of the humerus, but it is interrupted here. It is not attached to the intertubercular or bicipital groove. Here it is interrupted. Why it is interrupted, that we will discuss later on. So it is attached to the all about the anatomical neck. And on the scapular side, the fibrous capsule is attached a little bit away from the rim, bony rim of the glenoid cavity, in such a way that supraglenoid tubercle is intracapsular, while the infraglenoid tubercle is extracapsular. That is what is called the circumferential attachment of the fibrous capsule, both on the humerus side as well as on the glenoid side of the scapula. So supraglenoid is intracapsular, extraglenoid. So due to this, it is also circumferential. It is also circumferential. So this is how the fibrous capsule, they are continuous with each other. Another thing about this fibrous capsule is that it has got an opening below the subscapularis muscle, and this opening leads to the formation of a bursa also. The inner surface or the internal surface of the fibrous capsule is smooth. Why it is smooth? Because of the attachment of the synovial membrane. So synovial membrane is attached to the inner surface of the fibrous capsule, while the outside of the fibrous capsule is rough because of the attachment of the ligaments and the other structures. So this is we have cut the fibrous capsule from the anterior, and we have just separated the scapula from the front side. So we see the inside story. So inside of the fibrous capsule is shining, glistening and smooth because of the synovial membrane which produces the synovial fluid. So that is how it is attached. Another peculiarity of this fibrous capsule is that inferiorly it is extended downward over the surgical neck of the humerus. So there is a downward extension of the fibrous capsule medially up to the surgical neck of the humerus. The surgical neck of the humerus is called surgical because surgery is required after its fracture. Patient has to be shifted to the operation table. That's why it's called the surgical neck. Why? Because we know that surgical neck of the humerus is touched by the nerve that is called the circumflex nerve, or what is called axillary nerve, along with the posterior circumflex humeral vessels. So whenever a patient comes with the fracture of the surgical neck of the humerus, there are chances that this axillary nerve is trapped in the fragments of the fractured fragments, and it may be crushed and injured. And patient has to be shifted to the operation table, and patient has to be operated. We have to expose the surgical neck and we have to repair the nerve. That's why it's called the surgical neck of the humerus. So this is the anatomical neck, this is the surgical neck. In between the two, this is the epiphyseal neck. So humerus has got three necks. One is the anatomical neck, which is just adjacent to the head. Another is this is the surgical neck. The surgical neck is the most fractured part of the humerus. Why it is fractured most commonly? Because there is a sudden narrowness of the upper end of the humerus into the neck. So when there is a sudden change in the curvature, that becomes the weak point of any bone. So this is the weak point of the humerus because the upper end of the humerus is globular, bigger, and suddenly it narrows to become the shaft. So this sudden narrowness is the cause of fracture, and unluckily at the same point here it is touched by the axillary nerve and the posterior circumflex humeral vessels. So that's why it is called the surgical neck of the humerus. So there is a downward extension of the fibrous capsule medially up to the surgical neck of the humerus. This downward extension of the fibrous capsule has got the plus point, that is we can abduct the shoulder joint and the arm above the head or up to 180 degree. And the negative point of this inferior extension is that it forms a pouch-like structure of the fibrous capsule inferomedially, and this is the cause of the recurrent dislocation of the shoulder joint. So the head of the humerus may slip into this pouch formed by the inferior extension, and that lead to the dislocation of the shoulder joint. So that is the negative point. So this is what we know about the fibrous capsule, its attachment, its inferior extension, and there is the aperture or the hole in the fibrous capsule through which the subscapular bursa is present. So this is the extension of the joint cavity. The synovial membrane comes out of this foramen in the fibrous capsule in relation to the subscapular tendon, and this is called the subscapular bursa. So there are so many bursas present around the shoulder joint, but this is the bursa which has got a communication with the cavity of the shoulder joint, that is subscapular bursa. Then comes the ligaments. So ligaments of the shoulder joint. The ligaments, they are present inside. They are called the intrinsic ligament, that is called the labrum, glenoides, then transverse, humeral ligament, then there is a coracohumeral ligament, and there is a glenohumeral ligament. So these ligaments, they are present in which the labrum glenoide is inside the fiber. And this labrum glenoide is attached to the entire circumference bony rim of the glenoid cavity and is made up of the fibrocartilage. And superiorly, it is continuous with the long head of the bicep muscle. As long head of the bicep muscle is, its origin is very special. So origin of the long head of the bicep is intracapsular but extrasynovial. Intracapsular but extrasynovial. And takes origin from the supraglenoid tendon, supraglenoid tubercle, and its origin is intracapsular, extrasynovial, and it is tendinous. Same, these three words we use for the origin of one of the muscle of the lower limb, that is called popliteus. So from the supraglenoid tubercle, long head of the bicep, and from the infraglenoid tubercle there is a long head of tricep. But the origin of the tricep long head is outside the fibrous, so it is extracapsular. But long head of the bicep is intracapsular. That's why we are encircled around it. And this fibrocartilage labrum glenoide looks like the labrum is lip-like. It deepens, its function is that it deepens the otherwise shallow glenoid cavity and it prevents the dislocation of the shoulder joint to some extent. But because of the tear of this glenoid cavity, labrum glenoide, there is a dislocation of the shoulder joint tubercle. And if we cut this labrum glenoide, then what we see that it is triangular in shape. Made up of fibrocartilage, its peripheral part is attached to the bony rim of the glenoid cavity. It is around the bony rim. And its central part is thin. And it makes the glenoid cavity a much deeper. So it deepens it. So thick part is attached to the periphery, while the thin central part of the fibrocartilage, that is labrum, is centrally placed. So that is the position and cut section in the triangular part of it. Then comes the transverse femoral ligament. So this long head of the bicep is taking origin from here. It passes intracapsular and then it becomes extracapsular. It comes outside the fibrous capsule and runs into the bicipital groove. That's why it is called the bicipital groove, because the long head of the bicep tendon is accommodated here. But it is present inside the fibrous capsule, but it is covered by the synovial membrane. That's why it is called extracapsular but intracapsular but extrasynovial. Extrasynovial means it is present between the fibrous capsule and synovial membrane. Fibrous capsule is outside and synovial membrane is inside. So in between these two layers runs the long head of the bicep, and then it comes out of the aperture. A hole is present in the fibrous capsule. As we have said that fibrous capsule on the anatomical leg is interrupted here. Why it is interrupted? Now this is the answer now. Because long head of the bicep has to come outside the joint. It has to becomes extracapsular, like the popliteus tendon we have done in the lower limb. So that's why there is no fibrous capsule attachment to the anatomical neck is having no fibrous capsule attachment. And this is for facilitating the long head of the bicep. And with the long head of the bicep, the synovial membrane also comes a little bit covering the long head of the bicep. Now this long head of the bicep is held in position in the intertubercular or the bicipital groove due to this ligament, the transverse humeral ligament. And this transverse humeral ligament is attached to the lateral lip and the medial lip of the bicipital groove superiorly. The upper part of the bicipital groove is having a tunnel is formed. This tunnel is made by this transversely running capsule, that is the transverse humeral ligament, which held the long head of the bicep in the bicipital groove in all movements around the shoulder joint. So this is the small transverse humeral ligament. So this long head of the bicep, it also having the function to keep the head of the humerus in touch with the glenoid cavity in all movements. So it tries to prevent dislocation. So because of this long head of the bicep, which is coming from the fibrous capsule, taken from the supraglenoid tubercle, and then it passing above the head of the humerus, and then passing in the bicipital groove. So in this way, the standard of the bicep keeps the head of the humerus in touch with the glenoid cavity. So it also stretching from the supraglenoid tubercle to the bicipital groove. So this distance is very, very important to prevent the dislocation. So this intracapsular course of the long head of the bicep is one of the measures to strengthen the otherwise weak multi-axial shoulder joint. So that is the mechanism. Now the next is the coracohumeral ligament. As the name suggests, so there is a coracoid process there. So this is the base of the coracoid process. So from the base of the coracoid process, a ligament is stretching and attached to the greater tubercle of the humerus. So attachment of the coracohumeral ligament is on the scapular side. It is attached to the base of the coracoid process, and on the humeral side it is attached to the greater tubercle. So this ligament is present superiorly and anteriorly, and hence it prevents the superior and the anterior dislocation of the shoulder joint. So that is called the coracohumeral ligament. Then the glenohumeral ligament. As the name suggests, it starts from glenoid cavity to the humerus. So this glenohumeral ligament actually has got three parts: superior, middle, and inferior. So the superior part is attached to the anterior border of the scapula, glenoid cavity. Then the middle part, and lower is the inferior part of the glenohumeral ligament. The superior part is attached to the greater tubercle. The middle part is also attached to the greater tubercle. The inferior part is attached inferiorly, anterior inferior, and attached to the lesser tubercle. So in this way, anteriorly, the three parts of the glenohumeral ligament prevent the anterior dislocation of the shoulder joint, which is very, very common dislocation. But these three ligaments, they prevent the anterior and the inferior dislocation of the glenohumeral ligament. So that is the how we discuss the ligaments and the fibrous capsule of the shoulder joint. Now comes the blood supply. The blood supply of the joint is done by the various arteries around it. This is the posterior circumflex femoral artery. The anterior circumflex also anastomoses with them, and it runs in the bicipital groove and also supplies the transverse femoral and the longer of the bicep also. Then an artery runs along the lateral border of the scapula, lateral or the subscapular artery. So it also supplies the fibrous capsule and the shoulder joint. Regarding nerve supply, branches of the axillary nerve, they also supply it. The articular branches, they supply the shoulder joint. So these are the how we do. Then come the movements and muscles producing them. As we have already said that it is a multi-axial joint. So many movements are possible. So the anterior is called the flexion. This is the extension. This is the adduction. This is the abduction. And this is the medial rotation. And this is the lateral rotation. And when we move like this is the circumduction. So these are the various movements are producing flexion, extension, adduction, abduction, medial rotation, lateral rotation, and cricket bowling. Cricket bowling, this is the circumduction. And this is the abduction from 0 degree to 180 degree. So these movements, which muscles they produce, we have to enlist them. So muscles which are producing them, the various movements. First is the flexion. So flexion movement is produced by the pectoralis major muscle. Pectoralis major and the anterior fibers of the or clavicular fibers of deltoid. Then the extension, backward movement. So extension is done by the teres major with latissimus dorsi and posterior fibers of the deltoid muscle. Posterior fibers of the deltoid muscle, they also bring about these movements. Then come the adduction. So adduction is done by pectoralis major muscle as well as the anterior fibers of the deltoid muscle. The flexion is also done by the anterior fibers of the deltoid along with the biceps and coracobrachialis. They also bring about the flexion movements. Then the abduction. So abduction movement is done by various muscles from 0 to 15 degree. So first 15 degree abduction. The most functional position of the upper limb is the first 15 degree abduction. While we are writing, while we are eating, so 15 degree abduction is there. And which muscle is doing is supraspinatus. Then from 15 to 90 degree is done by deltoid muscle, middle fibers. So from 15 to, this is 15 degree but done by supraspinatus, then 15 to 90 degree. This is done by middle fibers of the deltoid. Then from 90 degree abduction to 180 degree. So from 90 to 180 degree, that the above head abduction of the shoulder joint is done by the various muscles. One is the serratus anterior, then trapezius, So that is called the overhead abduction. And this inferior extension of the fibrous capsule, it also facilitates this overhead abduction. If there would have been no any inferior extension of the shoulder joint fibrous capsule here, or the fibrous capsule might have attached to anatomical neck only, then we won't be able to abduct the arm above the 90 degree. Because here the fibrous capsule will be stretched between the glenoid cavity and the humerus. And overhead abduction would have been absent. But because of its inferior extension, there are chances that we may abduct it. So see how we do, how these muscles they break. So this is the 90 degree abduction is done by the middle fibers or the acromial fibers of the deltoid muscle. We take origin from the tip of the acromion, and these muscles they are inserted into the deltoid tuberosity. So when it can only do abduct the arm, the middle deltoid fibers only up to the 90 degree. Because in this position, now the muscle fibers from the deltoid, middle fibers and the deltoid tuberosity with the insertion, now the muscle is horizontal. Muscle is horizontal, it cannot abduct it in the above the 90 degree. So how the 90 degree abduction is done? So there are two mechanisms occurs. Number one is the serratus anterior come into line. And we know serratus anterior is inserted into the anterior surface of the medial border of the scapula here. Anterior surface of medial fiber. So these serratus anterior muscle goes from the ribs and inserted backside, like my 8 fingers, 8 digitations. They go along the curvature of the ribs and they go backside. And in the backside, they are all inserted into the superior angle to the inferior angle of the scapula, medial border, with surface anterior one. So when we have to move the arm above the 90 degree, so this serratus anterior muscle will act. And what it will do? Now it will contract and it will keep the scapula in touch with the ribs. So in other way, it fixes the scapula with the ribs or the human body or the thoracic wall. What the serratus anterior is doing. And what is the trapezius is doing? Now when the serratus anterior fixes the scapula with our posterior part of the ribs, now it is fixed. Now what happens? It also tilted a little bit up. So there is a slight degree of rotation of the scapula also done by the serratus anterior. The rest of the thing is done by the trapezius. As we know, trapezius is taking insertion into the upper border of the spine of the scapula here. So here is the attachment of the trapezius to the entire length of the spine of the scapula, from its medial to the lateral angle of the acromion. So when the serratus anterior has done the fixation of the scapula with a little upward rotation, then the trapezius will contract because it takes origin from the medial 1/3 of the superior nuchal line and all the spines of the cervical and the thoracic vertebra. So this trapezius will now contract, and with the contraction of the trapezius, what will happen? That the spine will be raised up and there will be rotational movement of the scapula. So serratus anterior fixes the scapula with the ribs, while the trapezius will lift the scapula upward, and when already abducted arm at the 90 degree by the acromial or middle fibers of the deltoid is already have done this position. Now when the trapezius will contract, then what will happen? The scapula along with the upper limb or the humerus will go up. And this is the final position that is called the 180 degree abduction is done when the scapula is moved upward along with the whole of the upper limb. That is done by a strong muscle, that is the trapezius, taking origin from here and attached to the whole of the upper border of the spine. So the whole of the scapula will be rotated upward. Why? The serratus anterior will brace the scapula with the thoracic cage or the ribs. So that is how the two muscles, they come into the force, come into the light, and they bring about the 180-degree abduction. So that is how we do the movements of the shoulder joint. Then comes the medial rotation. So this is the medial rotation. So this is the medial rotation is done like this. So this medial rotation is done by the, again by the pectoralis major muscle and the anterior fibers of the deltoid also. They bring about the medial rotation. Then the lateral rotation. The lateral rotators, they are the SIT sit. That is supraspinatus, infraspinatus, and the teres minor. So these muscles, they bring about the lateral rotation, because they all attach to the posterior part of the scapula, and supraspinatus is inserted here on the greater tubercle, infraspinatus, teres minor from here. So they are all attached to the greater tubercle, SIT. So when they will contract posteriorly, so humerus will be rotated laterally. So that is called the lateral rotators of the shoulder joint. And the circumflexion, that the cricket bowling, is the sum of the all the movements of the shoulder joint. All the muscles, they contribute in the circumflexion movements. Now last comes the applied aspect. The applied of the shoulder joint is one by one we will do. In the applied, first of all, is the fracture of the surgical neck. As we have done, that surgical neck is fractured, most common because of the sudden narrowness. So fracture is common. So whenever there is a fracture, circumflex nerve will be damaged. And the circumflex nerve, when it is damaged, it leads to the paralysis of the deltoid muscle, because deltoid muscle is supplied by the axillary nerve or the circumflex nerve. And as the shoulder joint is surrounded by as this is the fibrous capsule of the shoulder joint, covering the glenoid cavity and this anterior aspect, and there is the inferior extension up to the surgical neck. And this is the long yard of the bicep, lying in the biceps groove, a little bit covered by the synovial membrane, but covered by the transverse humeral ligament, and these are the superior, middle, and inferior glenohumeral ligaments, and here come the coracohumeral ligament from the base of the coracoid process of the scapula. So they are all fused with it. Fibrous capsule. So it gives the outside support to the otherwise weak joint. The various ligaments, they cover it anteriorly. So in the fracture of the surgical neck, if it occurs here, the axillary nerve is damaged, and due to the damage to the axillary nerve, and as we know, the deltoid is covering anteriorly, taken from the lateral 1/3 of the clavicle and inserting into the deltoid tuberosity. So this deltoid muscle is paralyzed because of the injury to the axillary or the circumflex. And paralysis of this deltoid muscle will lead to the inability to abduction from 15 to 90 degrees. Plus, there is a loss of the contour of the shoulder, the surgical neck. So this contour of the shoulder, because of the atrophy of the paralysis of the muscle, becomes flat, and the contour of the roundness of the shoulder is also lost. So that is the surgical neck fracture. The second is the subscapular bursitis. So as we know, the subscapular bursa is in relation to the subscapularis muscle. So the inflammation or the infection of this bursa lead to the pain in the vessel tubercle, and that is called the bursitis. Subscapular bursitis may be there. So patient come with the painful restriction of the movement of the shoulder joint. Another condition related is the recurrent dislocation. Recurrent dislocation of the shoulder joint, which is also very common. And this recurrent dislocation of the joint, various factors they act on the shoulder joint, which bring about the inferior dislocation is very common, anterior dislocation is less, superior is not. Because superiorly there is a coracohumeral ligament, plus there is also acromioclavicular ligament. So from the acromioclavicular ligament, from the acromion process to the clavicle, so superior dislocation is not possible because this ligament prevents it. Along with the coracohumeral ligament also prevent it. So there is a bursa is also present in relation to the supraspinatus muscle as it passes below the the acromioclavicular ligament. So just between the bone, and this is also called the subdeltoid ligament, subdeltoid bursa also, because it is present below the deltoid, below the acromioclavicular ligament, in relation to the narrow tendon of the supraspinatus muscle, while it is passing laterally for the insertion into the top point of the humerus, that is on the greater tubercle. So the recurrent dislocation is common because of the sudden lifting of some heavy weight. Patient is unable to lift it, and there is a dislocation inferior. So anterior dislocation is not possible because of the attachment of the various ligaments anteriorly. Posterior dislocation is also possible because posteriorly there is no any ligament. Inferior dislocation is very common because of the inferior extension of the fibrous capsule up to the surgical neck. Superior dislocation is not possible because of the presence of the acromioclavicular ligament. So dislocation is very common in the inferior dislocation because of the inferior extension of the synovial membrane along with the fibrous capsule up to the surgical neck. And posteriorly is also not possible because posteriorly there is a musculotendinous cuff or a rotator cuff is there, which fuses posteriorly with the fibrous capsule, and they strengthen the joint and keep the head of the humerus in contact with the glenoid cavity in all movements around the shoulder joint. So rotator cuff is also a plus point or the measure to minimize the posterior dislocation of the shoulder. So only dislocation is very common is the inferior dislocation, that is called recurrent dislocation in some people. After some time again there is a dislocation. So this dislocation is possible when there is a tear in the labrum glenoidi. So in these patients the labrum glenoidi is tear, and after tearing it the head of the humerus is slipped down because there is a fibrous capsule extension is there up to the surgical neck like this. So due to the inferior extension of the fibrous capsule, the head of the humerus, it slips easily into this pouch-like structure. So one is measure is that in this recurrent dislocation there is a tear of the labrum glenoidi, and secondly, another things which contribute in the recurrent dislocation is the 4G. 4G, you have to remember. Number first is who is the culprit? Glenoid cavity. As you know, compare this shoulder joint with the hip joint. There is a deep acetabulum in the hip joint, but see the glenoid cavity is very, very shallow. And this shallow cavity will cause the dislocation, because the head of the humerus is not touching the, gripping the into the glenoid cavity. So that will be. Then gravity. So the gravity also contribute in the dislocation. So whenever there is a lifting of heavy weight more than the capacity of a person, there is a dislocation. Then gyration. Gyration means multi-axial movement. We can move the arm into any position because of the shoulder joint is a multi-axial joint. So more is the axial movement, more movement, frequent movements are there, more chances of the dislocation. So that again the gyrations. Then geometry. So geometry of this shoulder joint is not congruent. The head of the humerus is spherical, and see the glenoid cavity is triangular. So there is no match between the two. And this mismatching is the problem in the geometries. The geometry of the both the ends which are taking part, two bones taking part in the joint formation is different, is not compatible. So that is the problem in the geometry. So that is the again, so that you have to remember 4 G's, which make the joint weak. The fourth problem of this shoulder joint is the ankylosis, or what is called frozen shoulder. So frozen shoulder is the restricted movement of the joint. Usually it occurs after the age of the 50 years, most common in the females. And there is a fusion of the aponeurotic musculotendinous cuff with the fibrous capsule. And the fibrous capsule also undergo capsulitis. So there is an inflammation of the capsule and synovial membrane inside it. And because of this fibrosis and there is ankylosis there, restricted movements are there. So head of the humerus comes very, very close to the glenoid cavity, and that leads to the frozen shoulder. So movement becomes very difficult. Patient is unable to abduct the arm, or flexion and extension movement, they are restricted because both the bones are coming very, very together. There is no any space in the joint is left. So that did. The treatment of this is that we have to give the physiotherapy exercises, and we also give the intra-articular injections also. So shoulder joint is also the one of the site for the intra-articular injections are given, made up of the xylocaine and a proteolytic enzyme, that is the hylase, with the local anesthetic, that is the lignocaine, is mixed, and the steroid, the lignocaine and the hylase. So three injections they combine together and we put just below the tip of the acromion. So it is very easy to inject intra-articularly with the full antiseptic conditions has to be aware. Then we put the injection syringe just below the tip of the acromion, so it will directly go into the joint cavity and capsulitis is treated. After that, the regular exercise of in all movements of the shoulder joint is advocated to the patients. So usually these injections are given weekly. So 2, 3 or 4 week injections, they are sufficient to make it movable joint. Then comes the Supraspinatus Tendinitis. As you know, the supraspinatus muscle is bringing about the first 0 to 15 degree abduction, the most functional position of the hand during the right